Keeley, Chantal, I am looking forward to a bold, informative conversation about incontinence. Over to you.
Thank you so much, Carmen, for the lovely introduction. We are both very excited to be here today to talk to you all about incontinence. We're hoping that whether you're a person that's struggling with their own incontinence or a clinician that's just looking to add a few strategies to provide their clients, that we are able to add some tools for you into your toolbox. We wanted to take this opportunity to just educate our audience today about a few of the different things that pelvic physios can treat. I think that for a lot of people, they don't even know that we exist. And for those that do, they might not know everything that we can help you with. So we will treat everything from prolapse, sexual pain, urinary and fecal incontinence, bladder and bowel retention, constipation, painful and heavy periods. We'll support women through their pregnancy, whether that's with pain or exercise, and provide post-delivery care, both to vaginal and C-section deliveries. We'll help people with endometriosis, persistent hip, low back pain, abdominal pain, and diastasis. So as you can see, the list is quite extensive, and so we can help a lot of people. But today's focus is going to be on urinary incontinence. Urinary incontinence is going to affect approximately 1 in 3 women over their lifespan. What this means is that it's a very common condition, but we want you to understand that it's not normal. There are things that we can do to improve it or even cure it, which is fantastic. Physical therapy is considered first-line treatment in stress urinary incontinence, and we just have fantastic outcomes. If you see a pelvic physical therapist, you are 8 times more likely to be cured, and 17 more times more likely to be cured or have symptom improvement. I don't know about you, Keeley, but this is just, I think, fantastic. We don't have a lot of things that we do in the physio world that are this effective. We also have really strong evidence for treating overactive bladder when we pair it with lifestyle changes and medication. So today we're going to take a look at the 3 most common types of urinary incontinence: stress, urgency, and overflow. You'll see at the bottom of the slide here, I've just put a little asterisk with fecal incontinence. So some of the strategies that we are going to go through today might help with this. However, the cause for fecal incontinence can often be quite different than urinary. It could be IBS, rectal prolapse, Crohn's disease. And so that in itself could be a whole other presentation. So for today, we're just going to focus on the urinary incontinence. So the first one we're going to talk about is stress urinary incontinence, which is the involuntary loss of urine on effort or physical exertion. So these are the people that are going to come in and they're going to say, when I run or jump or cough, sneeze, laugh, I experience incontinence. I would say that this incontinence is probably one of the ones that is the most normalized. I know in my group of friends, it's kind of like a running joke where you laugh so hard, you have tears running down your legs. So one of those things that very normalized, but once again, not normal. Stress urinary incontinence does not discriminate. So we're going to see it in people of all different ages and fitness levels. One of the areas that this is going to commonly pop up is in pregnancy or post-delivery. I can say that I've had my own personal experience with this. After I had delivered my son via C-section, I was feeling pretty good about, 4 or 5 months in, and I was like, all right, I'm ready to go back to basketball and be active again. And within about 30 seconds of being on the court, I very quickly realized that I was no different than all of my patients, and I needed to do that gradual return to loading kind of program and focus more on my pelvic floor exercises. So it can definitely affect us all.
Yeah, I would say that if you're seeing a pelvic floor physiotherapist, we have had some symptoms in the area of pelvic floor, and we definitely know how you feel.
Yeah, most definitely. We're also going to see stress urinary incontinence with high-level athletes. So our gymnasts, our dancers, volleyball players, basketball players. So it can affect really athletic people as well. And those beginning impact exercises. So that might be because you've had a period off, either due to pregnancy or urgent or just injury. And we might also see it with people that are just changing what they're doing. So if you've been somebody that's been doing yoga or more Pilates, and all of a sudden you decide you want to take up tennis, it might pop up. And then people with increased weight or BMI, and then also with our perimenopausal and postmenopausal, which can be in part due to some of the hormone changes.
Mm-hmm. So yeah, we're also seeing just an increase in younger women doing kind of Olympic lifting or CrossFit. So just keep that in mind. If you're having leakage during those activities, it is not because you're lifting heavy weights. It's because you need to learn how to change how you're using your pelvic floor while doing it. Okay. The next area that we look at is urgency. So that's when you have the friend that can't complete the run and has to go into the bushes to relieve themselves, or the person that knows where every bathroom is before they get there, or goes before they go, and goes when they arrive, and goes between meetings, and goes between the phone call. And right now, we both went before the Zoom call. So that's urgency. You don't necessarily have to leak with that. And so then it's called overactive bladder. So there is kind of the two. Some of them mostly have triggers. So that's when you go key in the door, running water, maybe walking past that cold section or going into the winter weather outside. And even just kind of when you run, skip, you might have some urge that causes leakage, which is different than stress incontinence, which just kind of leaks without the urge. So some of the populations that I might see this in clinic are any population. Some start in early childhood, but don't know that we can help them deal with those issues. A lot of the times they're like, I have a small bladder. Well, no, you don't have a small bladder. Yes and no to that question, but you can change how much it can load. You can change how the muscles respond. So yeah, you don't have to deal with it if it's from childhood. You can definitely change it. If you have frequent bladder infections and you've gone and you got tested and there's no sign of bacteria, but you're still having that urgency, those infections can affect the tissues and how they respond as well and cause pelvic floor tightness sometimes. So that's a really good reason to come in to see what's going on with the muscles if the bladder infection is being treated, but you're still having those frequency and urgency symptoms. Sometimes the two are paired together, like stress incontinence and urgency come together. So then we're doing both of those. You can get it with pregnancy, and sorry ladies, yeah, that's kind of towards the end. The baby takes up a lot of room. There's some stuff we can do to help that if it's starting to interfere with your activity or day-to-day life for sure. But it definitely happens towards pregnancy. And of course, anytime your hormones change, the tissues are affected, your muscle tone is affected as you move into aging. So perimenopause, people start noticing, I didn't have this problem as much before, but I'm certainly noticing it now. So those are some of the populations that can get it. The next thing that can cause a lot of urge incontinence is bladder irritants. So yes, where do I see this a lot? Those students that start drinking coffee during their exam time start coming to me with those issues. Sometimes it can be the most common research triggers are, caffeine. It's very irritating to the bladder. Alcohol, smoking, and that concentrated urine. So if you're dehydrated, you're going to concentrate the urine and that's going to irritate the bladder. So on the list, you'll see some other items here as well. That's more sometimes when you're dealing with interstitial cystitis or overactive bladder, and sometimes those do help to remove those types of food, but you'd have to go through that with your health professional and kind of weed through it and see what happens. Now, we all know what happens when you leak, and this is what our patients all do. They stop drinking.
Yes, most definitely. And it seems really counterintuitive, but I'll talk to a lot of my patients and say, if we drink more water, that will actually help with the incontinence, because essentially what you're doing is you're helping dilute some of those bladder irritants. So they're not attacking that poor little bladder, and that can actually help with it.
Yeah,
So
supporting that tissue health of the bladder lining. Sometimes we say like it's like watering your rose or your flower, making sure it's nice and healthy. But yeah, it is very counterintuitive, but I've had people actually decrease their leaking by increasing their water.
Yeah.
Because they've decreased it so much over time.
Mm-hmm.
Yeah.
So next we're going to talk about overflow urinary incontinence, which is the involuntary release of urine from an overfull bladder, often in the absence of any urge to urinate. So I like to kind of explain this as almost like a water balloon that's reached its capacity. And when it reaches that capacity, eventually it's going to pop, or we're going to get the leaking. So these people are going to tell us that, all of a sudden their underwear feels a little bit wet, or they might smell urine, or when they go to the washroom, they've noticed that they've leaked. So the triggers for that is often not taking regular bathroom breaks. So shout out to all of our teachers and clinicians that go their whole 8-hour shift without once going to the washroom. This might kind of fit you. We can also, as we just talked about, we need to drink more water. For some people, we can actually drink too much water. I actually had a patient who's a great example of this. She was coming to see me after her third child, and prior to this had never had any issues with incontinence. And then she's talking to me and saying, I'm constantly leaking throughout the day. I don't know what's going on. So we start talking about kind of, her fluid consumption. And she tells me that she had seen one of the PCN nurses after her delivery, and in kind of the mom fog of having, 3 kids, she thought the nurse had told her to drink 8 liters of water a day instead of our typical 8 cups. 8 liters is a lot of water. And so, especially when you pair it on top of your coffee, maybe the occasional drink, any of the food stuff. But she was one of those patients that was super diligent, and she was going to do anything you asked her to. So she was the easiest patient I've ever had to treat. We just reduced her water intake, and then her incontinence basically resolved. We can also see overflow incontinence with certain medications. So that's just something to keep in your back pocket to talk to your doctor, maybe pharmacist about. And then we're also going to see this in people with neurological issues, just because their bladder isn't providing the right info to the brain. So they're not getting the same sensation that they actually have to pee. And then over time, that bladder is only human, it's going to reach its capacity. So people who are diabetic, with multiple sclerosis, spinal cord, nervous system injuries, we'll see that with them as well.
Yeah, so one other thing I just want to touch on for the neurological standpoint, sometimes during the birth, the baby's head can put pressure on the nerve if it's over a long period of time, or sometimes the muscle tear can affect the nerve. And so when you have a lot of leakage after the birth that is not resolving within the first 3 to 4 weeks, something is wrong. That is not normal. Please come in and talk to your OBGYN, talk to a pelvic floor physio, because something's wrong and you need some help. And there is actually special clinics to see women in the first 12 weeks who are really struggling after the birth. So that's when you can access those kind of resources. All right, just a quick touch on anatomy. So this is kind of what the pelvic floor looks like from the top down, looking at the pelvis. I just want to make sure you understand your hip muscles are also part of your pelvic floor muscles. So anytime you have a hip problem that's tied with some leakage, probably the two are connected. As you can see, there's 2 sphincters there, your anus sphincter and your urinary sphincter. And this is where people forget that fecal incontinence and urgency are the same thing in terms of, yes, we treat both, okay? So don't go and not include that in your talking to your doctor. They are the same thing when you're dealing with pelvic floor. We can help with those. These are the muscles also that relate to sexual function. So if you're having pain or discomfort for whatever reason that's new, this is where we can look at those muscles and see what's going on. We just don't treat Kegels anymore. So there's a lot of women that come in, they're like, I've done Kegels and they don't work. Yeah, you're right. We know more than that now. We have to look at the whole thing as a canister. So if you think of the pelvic floor as the basement of your house, and the back and the abdominals as your walls of your house, and the rib cage and the shoulders as your roof of your house, we actually have to look at that whole canister, because there's abdominal pressure, there's muscle tension, breathing works with the pelvic floor. So we actually assess all of those areas when we're going through that. So it's a very important part.
And just to kind of add on to that, I think, like you just mentioned, the hip muscles as well.
Right.
I include kind of our hips, our glutes as part of that core,
Yes.
Because they are so intertwined.
All right, so the physical therapy assessment. So we ask a lot of questions. I don't think people know. We ask about bowel, what type, how often. If you want to see what kind of questions we ask, and this is a great form to take to your doctor, it's a great form for you to look at and see kind of maybe what you're missing when you're looking at everything as a big picture. We have a sample assessment form on the WHC website. So on that form is going to be all the questions we ask, from how is it with sex? How often are you peeing? How much during the day? Is it every hour? Is it every half hour? Is it every 8 hours? How much are you drinking? What is your stress level? Like, we need to know all of those things, and you'll find it's a very long form, and it's very informative, especially when we can't touch your bladder. We can't take pictures of it. We need to know what's going on. And these are the questions we ask, and they definitely tell us things.
And I just think people are always floored that you can ask so many questions about how they pee. But when we actually go through that process, they realize all of these kind of unconscious habits that they've developed over the years, and kind of have this moment of realization like, wow, I think something needs to change with that.
Yeah. All right. Also on the WHC website is a sample bladder diary. This is really important, I think, for many reasons. We've all done, even as clinicians, this practice, and I always think I drink more water than I do.
Yeah.
Always. As soon as I start recording, I'm not drinking it. It also helps keep track of how much you're leaking, so that when you go through your treatment plan and you have a goal, you can see, are you changing the amount you're leaking? Are you changing your pad use? What are your triggers? Is it tied to coffee? Is it tied to going out the door? What kind of things is it tied to? I just want to touch on, if coffee is a trigger, no, you don't have to remove it for your rest of your life, okay? Ladies, it's just more about what can we do to change it for a temporary time frame to get the changes you want, and then you can add it back in, all right? So yeah, if you want to kind of do this, it's really nice and handy to have this, again, for your health professional done beforehand.
Mm-hmm.
We often give it out as needed after the assessment, but it is nice to have it done beforehand. So you can be like, oh yeah, I really go a lot. Or I don't empty well. That's very helpful for not emptying well. It tells us whether you are or aren't, and it's good for you to know as well.
For anybody that is looking to do this, or for clinicians that want to give it to their patients, we normally get people to do it over the course of 3 days, and that should give us a good representation of what your habits are. And I normally will get my patients to try to do one day as like a work day and another one during the weekend, because how we pee at work can be drastically different than what we're doing at home.
Yeah, exactly. All right, here's another picture again. You can see a finger, if you notice, doing the internal exam. So yes, I have had 3 patients this week come to do a pelvic assessment, not knowing that we do an internal exam. We are trained postgraduate to do this. We make jokes about it because Chantal's going to share what we have to do to learn about this. Ladies, you don't have to have the internal assessment done to get success with pelvic floor physio. Okay, so if you've had, a bad experience or just don't want anyone going down there, don't worry. All the things we've talked about, from strategies around bladder control and looking at that, even working the muscles around the hips and abdomen, can make a drastic difference for you without the internal exam. You always have to give consent. You always have a choice. And I want you to know that for any health professional you're seeing, you are allowed to say no. Even if you're there for that, you can still use their education and ask questions and get information without doing the internal. That's very valuable.
Well, and I don't know about you, but I've had some patients where maybe on the first assessment, they're not quite comfortable. But by the second or third, once you kind of develop that rapport, then they're like, okay, I want this information. And the information that we get from it is fantastic. I will never forget me going through my certification process with this. And we have to practice on each other when we do it. We don't just go into the clinic and be like, hey, you're my first patient. So, we take the course, we practice on each other. And the first time I did my first few internal exams in that course, I was just floored. I was like, wow, I've never experienced anything in the physio world where, you can just feel so immediately either that muscle is contracting or it's not. You can really feel the muscle tone. So it's a beautiful thing. We get a ton of information from it. But like Keeley said, we want you to be comfortable. And so you need to be comfortable, before we go ahead.
And like Chantal said, we know what it's like to be awkward with it. Going into a course and being like, do you want to be partners today? To someone you don't know. We know all about it. So yeah. All right, so the next slide here, again, also available to you on the Women's Health Coalition website, is our top stretches to help pelvic floor relaxation. So often with stress, incontinence, or urgency, they're like, don't I need to be stronger? No, you don't need to be stronger. We'll do a little demo of what stronger does to you. Sometimes you can do too many Kegels and make yourself worse. So these stretches, you've all seen them before, probably in yoga or maybe, in the gym or part of a stretch class, but they all address kind of the inner leg, the hip rotation, all the muscles that do tie in directly or indirectly to the pelvic floor, and they do actually help relax it. So on the site, there's a little bit more description in terms of how long you hold it. Do you do a Kegel with it, or do you do breathing exercises with it? For the majority of people, these stretches can really help. So they're up there for you to try out. If you need more guidance, again, going to a health professional is always helpful, but even just trying them on your own, seeing what changes you get, you can see what happens. And you were going to talk about maybe the bicep curl, kind of explain that tight muscle.
Yes, most definitely. So how I'll kind of talk about overactive pelvic floor with my clients is that sometimes, we need that pelvic floor to relax before we can actually go into strengthening it. And I'll compare it to a bicep curl. And so if your bicep is tight, we're not going to go and strengthen it just in this range. What we want to do is be able to strengthen it through that full range so that we can just have functional strengthening within it. So we're going to get that pelvic floor muscle to relax first, and then we're going to be a lot more successful in our strengthening. A tight muscle does not mean a strong muscle. Yeah. And so sometimes we have to work on the relaxation component first. So that's going to kind of bring us into treatment. So we put for treatment pelvic floor training because like Keeley hinted at before, sometimes we don't need to actually do our Kegels. We need to relax it first. So pelvic floor training is what we're going to look at. Along with that is we're going to do the core strengthening. So that's going back to that beautiful canister slide. And how I like to talk to my patients is say we're only as strong as our weakest link. And so with that, when we're exerting pressure on that core canister, that pressure is going to kind of want to take the path of least resistance if we don't have the actual strength to contain it. And so for some people, that might look like a back injury or hernia or incontinence. And so that's why it's really important that when we're looking at our clients, that we're treating all of those components together. The other thing that we're going to look at is just guidance on gradual return to impact exercise with a gradual loading schedule. That's what I should have been doing, kind of going into basketball. We're also going to look at bladder retraining for healthy habits. So that's pulling in all the information that we get from that bladder diary, from that lengthy subjective history that we took. And we're going to pull all those pieces together and just try to find small changes that we can make. We don't need to overhaul everything. Sometimes just a few key changes can make such a big difference. And then I think the biggest thing that we do as pelvic physios is we educate. I love talking to my patients about how their body works, why they have the symptoms that they do, and what they can do to improve their condition themselves. we very much want to give our patients the tools so that they don't need to come back and see us. We don't really have the clients, although there's the exception, but I think most of them, we want to give them the tools so they can go live their life. We don't want those lifelong clients.
No, and a little bit newer into that education is what I've started doing and some other clinicians started doing is how do you check your own muscles yourself at home? And we're trying to explain, and you might see it a little bit on social media, like here's what it would look like around the clock face. Here's what you'd be feeling internally if you were trying to check yourself, because the person that knows you the most is you. Guys have their stuff on the outside. We have it on the inside. We just don't get to, check it as often. So I'm trying to encourage women to take that time because your body changes throughout your life. Learning about it now helps you know if something changes, what's different. And then that helps you tell the practitioner what you've noticed, which is, it's valuable. So so that's another thing that we're, exploring with women as well.
So next, we're just gonna go into a few common questions that I think me and Keeley both field on a regular basis. The first one, Keeley, how do hormones influence leaking?
Yeah, so obviously this is a common question, and I feel like there's just not enough answers still in the research. It goes back and forth quite a bit from people being like, should I be on birth control or not? Should I do the estrogen cream in menopause or not? Definitely, it's still a factor. So we're still going to screen those questions. It does usually involve another healthcare professional. If you want to check levels in your blood, you check your tissue health. They are all related to hormones, and there's non-hormonal ways to treat those tissues in addition to creams or medications or things like that. You're going to notice hormonal changes in any stage of life, from pregnancy, menstruation to menopause. And anytime that change happens and the hormones change, you can get symptoms of urgency or frequency sometimes with the birth control too. Your body can be affected differently than someone else's. And so if something changes with your birth control that relates to any of that urgency, frequency, leakage, or even sexual pain, then something's going on with those tissues, and you want to kind of clear that as is it 10% of the problem? Is it 50% of the problem? What kind of percent is it? All right. Another thing that we get is like, sometimes our treatments just don't work, right? Sometimes they don't. So what else can you do? You don't want to be like, oh, I guess I just have to live with it. Nope. We're always going to tell you, you don't have to live with it. There's so many options now. So this is a pessary. As you can see from the screen there are many shapes and sizes. I kind of make a joke. It's like fitting a shoe for your vagina or a brace for your vagina.
I love
okay.
That.
You're going to have to try different sizes and different shapes. It's not a surgical procedure. Sometimes there's a misconception that we have to surgically insert these. Nope. It's kind of like a diaphragm where you put it in and you can take it out. Nurse incontinence advisors and some physiotherapists, depending on the location in Alberta, do fit these, and they're silicone. They don't harm you. They can even help you. And sometimes they're just easier. I've had a couple soccer players like, I just, I don't have time for these exercises. I got my kids and I really want to run. I really want to play soccer. Yeah. So they insert the ring, they play their sport, they don't leak, they're good. It can help sometimes with the urgency too at work and things like that. So don't worry, there's always different options out there. If you haven't had success, keep asking, come and ask us. We like to give you options too. Yeah. Pad usage, again, we're not like promoting pads as a way of treating this. We're promoting pads as a way of like keeping you active. There is a lot of research on the Canadian Incontinence Society showing that if you decrease your activity because of incontinence, it affects your health long term. This is really important to understand. Like, it doesn't seem like a problem to you, but if you've changed your activity because of this, you are already decreasing your health overall. So if you need to use a pad temporarily to do your activity while you're seeking treatment, go ahead and do that. Don't be ashamed of it. I think there's more acceptance of it these days, but don't become less active. Like, it's not going to help you in the long run.
And we know that increased activity is going to help strengthen those pelvic floor muscles, just general activity.
Yeah.
And so you might need to be wearing these just to build up some strength, and then hopefully it's something that you don't need to use long term.
I've had people just increase their activity and their leakage goes away, but they were willing to wear the pad to do it. So yeah. All right, so who else can help you? There is a wide range of people out there. So working in the urogynecology unit at the Royal Alex Lewis Hole Hospital for Women, I will say my best outcomes were when the team was involved. Okay, I can't do it all on my own. I prefer to have other healthcare professionals involved. You get way more information, you get way more support, way more tools. It's just easier. So there's the standard ones you can think of. Urogynecologist is great because they work on everything from your uterus to your bladder to your rectum. Gynecologists might have a more specific approach, but also very helpful. Family physicians are great, especially if you're worried about hormones or just want to talk to them about resources. I've had lots of doctors explain how to relax on the bathroom and help people with their urgency. So some of them do have some good information. Nurse practitioners, again, really good resource, work in the hospital and some work privately. Dietitian can be really great on the fecal incontinence side. I always say I really recommend a dietitian if you have fecal incontinence. If you have bladder stuff around coffee and intake and stuff, they're also helpful. They're very specific to this problem though, so this isn't a dietitian that helps you lose weight unless that's something you want. Psychologist is there as well in case, again, anxiety and stuff might be interfering with overactive bladder and frequency and urgency. There is a relationship between depression, anxiety, and overactive bladder and frequency. So that's where they come in. Massage therapy, any massage through your abdomen, glutes, inner leg can be helpful. So those are great. Acupuncture, also helpful, treats many different things in terms of the organ system, relaxation, and they have more research now showing kind of what it does. So it's a valuable tool as well. Did I miss anything?
Pharmacist.
Yeah. Oh, so good. Yeah. So the pharmacist is great for the medications that can affect frequency and urgency or cause overflow. Mm-hmm. I've had a couple pharmacists change the time that the patient takes the medication to impact their leakage. So those diuretics, any of the mental health medications can impact nighttime leakage, those kind of things too. So yeah.
Yeah, pharmacists are great resources, one that I don't feel we utilize enough. Mm-hmm. Relationship with my pharmacist and the information he's provided me has just been, so fantastic.
Yeah.
So who is appropriate for pelvic physio? We're obviously a little bit biased. I like to say anyone with a vagina is probably going to be appropriate for pelvic physio at some point during their life. So it doesn't mean that you necessarily need it right now. But if you are interested in, whether or not you would be appropriate, or if you're a clinician looking to see whether or not you should maybe refer your patient to a pelvic physio, we do have this cozy and pelvic dysfunction screening protocol. We will have this on the WHC website for you. And basically it just asks you a series of questions. And if you select 3 or more, then pelvic physio might be something that could be of benefit. We will also see anybody experiencing any pelvic related pain, incontinence, prolapse. So if you're experiencing any of that, you would definitely be appropriate. And then anybody that's interested in preventative care. I'm a huge advocate for preventative care. A very wise physio once told me to listen to the whispers so you don't hear the screams later. And I just thought that was so insightful. I think with us kind of normalizing a lot of the incontinence, if you do pee a little bit when you cough or sneeze, those are little whispers to your body. And right now they might not be affecting you, so it might not be necessarily a priority, but things can happen in life, whether that is, the birth of a baby, hormonal changes, injury, which can kind of tip you over to the other side where it does become an issue. And so if we can be proactive and preventative in taking care of yourself, then these become big issues later. And then also anybody interested in safely increasing physical activity through different phases of life. One of my favorite clients to see are women who are kind of preparing for retirement. And so finishing off a career, and unfortunately at this time it's often where they're going to be going through perimenopause or postmenopause, and so they're getting the hormone changes with a lot of like the incontinence that sometimes can go through with that, and they just want to be able to golf, play pickleball or tennis and just live their best life. And so that is just so rewarding because we can kind of guide them through that so that hopefully they're able to do that without issue.
Yeah, and then just to talk about this screen, it is new. So 2018 is when it has a 98% in terms of if you check 3 or more of these, you have pelvic floor dysfunction. So check through some of them. They're not the ones you think sometimes. So even the sexual activity increases one or more of my symptoms, increases my symptoms. Like, yeah, people are surprised about the questions. As soon as you check 3, your pelvic floor is involved with your problem. Okay. All right. You're like, how do I find a physio that does this? So we have a website. Even if you just Google find a physio Alberta, you'll be able to select by specialty. So there's 3 that you can check on. There's pelvic pain and conditions. There's incontinence, urinary, and fecal incontinence. So you can filter by the condition, find out who's in your area, filter by the city, even see who's closest, and just ask the questions, make sure they do an internal exam and it's available to you if it, and go from there.
So that's the end of our kind of formal presentation. We hope that you guys got a lot of information. We are open to just like opening the floor for questions now, if there's any out there.
Thank you, Keeley and Chantal, for that very informative conversation, and you did help us open up conversations about things that are often too embarrassing or uncomfortable or personal to talk about, and that really is the key to better conversations for better health. The Women's Health Coalition is all about telling personal stories, and I think you also brought this presentation to life by sharing some of your own personal experiences. And I appreciate that. You made this a very engaging session. And we do have some questions. People were sending questions throughout your presentation, and I think many of them got answered along the way, but I might revisit a couple just for some clarification. One new question that came up was, how do I know if I'm doing Kegel correctly?
That is a fantastic question. I can take that one. So there's a few different ways that we can do that. One thing that I'll recommend to my clients is just to do a self-internal exam. So you're gonna stick your finger up your vagina, and what you should feel is a gentle squeeze. And if you have pretty decent strength, you might feel a little bit of a lift. With that, I often will get people to do a little bit of visualization. There's different cues that we can give that will assist people in maybe connecting with those. And some of them are completely ridiculous. I'll tell my patients to imagine that they're picking up a blueberry with their vagina, or that they're drinking a milkshake through a straw through their vagina, or you have bugs crawling up your legs and you're trying to close it off. So there's lots of great visual cues that we can use. If you're still not having success with that, I'll get my patients to try to go to the bathroom and try to stop peeing midstream. Now, with this, like, in no way are we saying use this as a strengthening exercise. That's not what I want the take home to be with this. When we go to the washroom, our pelvic floor should relax, but as just a one-off to kind of give it a go and see if you can get that contraction, you can try that, and that might kind of give you the feedback that you need. You can also try almost pretending like you're trying to hold in a fart. So that'll get you more of those posterior fibers. So those are a few things that'll get people to try out. Another thing that people can purchase is a biofeedback machine. So this is where we insert a probe into the vagina. I call it vagina video games. And so it's basically almost like inserting a dildo. And then this is going to connect to your phone, and it's going to give you feedback on the pressure. And so for some people, it's a great way for them to kind of see, okay, am I actually doing pressure? And then to track their progress. If you're somebody that gets bored with kind of doing the classic Kegels, but are looking for some targeted training, then it's just a different way that you can do it. And then like we kind of discussed throughout the presentation, you know, as much as doing Kegels are, you know, a form of exercise, it's not the end all be all. So, you know, if you're having any issues, even just trying to be more active, and then if you're still struggling, go see a pelvic physio, because we have so many tools that we can use to assist you with that.
Yeah.
Do you have anything else you would add
Some
on
people,
it?
yeah, just they've tried the Kegel and it just doesn't work, and they feel like, oh, well, I guess I'm done.
Yeah.
And it's not. Like, you know, now doing different hip strengthening exercises or abdominal strengthening exercises will actually increase the muscle bulk and contraction of your pelvic floor. There's, again, newer research that comes out showing, like, it's okay if you don't know how to do it. It's okay. Come and learn the other exercises. Okay.
Sorry, I muted myself. Thank you both for the answers and for those descriptions that I will be thinking about for the rest of the day, I'm sure, if not longer. So I have some really specific questions, and this one's longer, but I'm going to read it out because I don't want to get it wrong. This individual said, I used to experience UTIs rather frequently. Recently, she is now 52 and perhaps perimenopausal. She's experienced some of the heat in the area while sitting or urinating, yet tests have confirmed that there is no infection. Could this be a pelvic floor issue?
Yeah, this is like a common, I would say a common complaint we see in the clinic when we're asking those questions. And definitely, yes. So then we'll be checking for, on the exam, looking at the tissue health, because I want to see if there's any redness, irritation around the vaginal entrance or around the urethra. And that tells me how the tissue's doing from a hormonal standpoint. Sometimes when you have constant urge to go, you get tight, because it's normal when you feel urgency to be like this. And so then that can contribute to like low blood flow to the area, can put that pressure on the bladder sensors, because the bladder is very sensitive to pressure and tension. And so, yeah, just learning to relax and let go can help. It sounds like a combo there because of the burning or warmth that she feels, but there'd be some tissue stuff and some muscle stuff as well.
Yeah, I would agree.
So one of the questions is, this is a combination question. If somebody is a new patient, what can they expect in that first appointment, and what kind of expectation could they have about how long treatment will take before they can expect to see improvements?
That's a great question. So like we kind of discussed, that first appointment is going to have a very thorough subjective history. We are going to ask you so many questions. And to be honest with some of my patients, sometimes that's all we have time to get through. And I know both me and Keeley and almost anybody that I know that works in the pelvic world, we book long times. It's not something where you're getting rushed in and out. So you can expect to be in the clinic for an hour and a half for that first appointment. Where we're going to ask a lot of questions. If we have time, we'll probably take a look externally at, how your body is moving. And then it may include that internal exam if you're feeling comfortable with that. So that's kind of what the first session will look like. Now, in terms of, how quick you're going to see results and how many treatments you need, that's going to be different, I think, for every patient. I would say, though, like most of my patients get results pretty quickly, depending on what the issues are. If we're trying to make modifications to some of their bladder habits or those bladder irritants, some of my patients will come back the next week and they're feeling significantly better. Like I kind of talked about before, I think our strategies are giving women tools so that they can, do a lot of that treatment themselves. And so it also just depends on how good they are. I have, new moms who this is just not a priority for them, and that is totally okay. They might take these tools and they might use them 6 months, a year down the road. So yeah, I would say it's more individual.
So I kind of give a general though, just so people know. So I usually say between 4 and 6 treatments, you should be seeing a change, because if you're not seeing a change by like at least 4 or at least this, we're missing something. And that's when I refer you to another practitioner, because something I'm not catching something or I'm missing something. When I say 4 to 6, that might be every 2 weeks. So that would be over a 2-month period, because you do have to implement some changes. It takes time. I ask you how much time it's going to take you to do it. And then your appointments, those 4 to 6 appointments could be over 2 to 3 months, right? So and then I'm saying, okay, you might be feeling better within 3 to 6 months, right? So again, yes, everyone is different. Some people are shorter than that time frame, some are longer than that time frame, but that is a general guideline. You do want to be seeing changes within 4 to 6, or something is, we're missing something. Need more help, whatever. Okay.
Thank you for that. That was great. I think that's exactly what people wanted to know. Somebody has asked about the Photona machine and its effectiveness in pelvic floor health or pelvic floor treatment.
No, I don't. I'm not familiar with that one. Possibly
No.
could do a social media post if we go and look it up and then post on it. Give our opinion.
The BioStim machines, if it's similar to that might have been what I touched base on. And the ones that I'll commonly see are the LV, the PeriFit. So there's a bunch out there, but yeah, I can't say that I've heard of that one. Sorry for whoever asked that. We'll look into it for you.
So I was so glad that you guys were you both were so open about fecal incontinence, because honestly, I had never heard that term before. And I know that people would be might be very embarrassed and intimidated to open that conversation. So one of our attendees today wanted to thank you for bringing that up. And then also asked whether or not the treatments for incontinence or fecal incontinence is covered by Alberta Health.
Ooh, that's a loaded one. So in the physio world, unfortunately, we've recently, I think as of April, they've cut a significant amount of funding. Now, certain clinics had access to this funding, and some pelvic physios would access it. I know that I did. But unfortunately, the government has completely axed this. I think there might be a little bit left for low income. Am I right on that one? For low income, but not necessarily pelvic health, because there's a different allotment of funding given to different problems. So it is unfortunate that the government pulled that from private clinics. Now, if you want AHS to cover you, you got to get a referral to the Royal Alec, the urogynecology clinic there. They have, again, like, I think 6 to 9 physios right now. They have the urogynecologist, the pharmacist, they have the whole team. That's where you can access specifically physiotherapy that's funded. It's a year wait list. Sometimes longer. But the positive is if you do have any private coverage, a lot of times physio will be covered under that, at least a portion of it, or maybe your first few sessions. So
if you have extended healthcare benefits that are physio, they're covered for this.
Thank you for that. That was very helpful. And I was going to ask the question about private. So I really appreciate that you went down that path. And this may be an area where the Women's Health Coalition can have more conversations about where this fits into, the better health system for women. Now, there's a couple of other questions. What is normal for urination frequency if an individual is drinking 8 glasses of water per day spread during the working hours?
Well, I think that's a hard one. I don't like to kind of blanket, and I don't know if me and Keeley are different on this. I think every individual's kind of hydration needs are going to be different based off of the activities that they're doing, what other kind of fluids they're consuming. But if we were to kind of generalize, I will normally tell my patients somewhere between 6 to 8 times. So we should be peeing about every 2 to 3 hours. Would you agree with that?
Yeah. So the general, if you look online or if you look it up and see, on social media, the general guideline is you should be peeing every 2 to 3 hours. But I have some patients that drink 3 liters of water a day for health reasons or hydration, and they might pee a little bit more. When do you want to see us? When that peeing is interfering with your workouts, your work life, your home life. I don't care what volume of water you drink. If it's starting to interfere with something, there's ways we can change that without impacting the volume of water you drink. Okay, because some people are like, well, it's just because I drink so much. Not really. No. So you can drink a lot and still have control.
Unless you're at that like 8 liters.
Unless you're the 8 liters.
Yeah, 8 liters is a little
then
bit much.
So one of the other questions that somebody has asked is, you had referred to easing back into exercise, high impact exercising. How is that progression done? How do you ease back into being able to jump again?
Yeah, so it's easy. Well, I should say, when I've taught it, like say to a postpartum mom group, and they will put up their hand, like maybe 5 of them in the class that leak when they jump. I'm like, great, stand up. We're going to do it right now. So if you want to take these tips and write them down and try them out, they can work instantaneously. First, I'm going to tell you, when you're standing before you jump, try to soften or let go of tension in your pelvic floor and abdomen. Most people, when they leak, when they jump, really try to pre-clench, but that goes into that rigid muscle that we were describing, as no flexibility, no contractibility when you're already holding before you jump. So first is to try to relax, and just that one, and try jumping. Maybe it helps, maybe it doesn't. Move to the next one. When you jump, every time you land, you breathe out. Okay, so if you're jumping, it'd be like every time you land. If that still has a little bit of leakage, but it seemed to help, you would modify that load by just doing heel taps and doing breathing out with heel taps. And then there'd be this progression of like a minute or 2 minutes or numbers with that, but you can try it and see how it works. The second thing that people do when they jump is they actually tend to jump backwards sometimes, especially if they've added tension to their abdomen or back. If you jump forward slightly, I'm not talking like meters, I'm talking like millimeters forward as you jump, it activates the front abdomen and front pelvic floor fibers to help control. So even just this forward jump can make a difference right away for people noticing leakage when they jump. If you're a CrossFitter and you do double unders and that's when you leak, or if it's when you skip, most often, this is actually a technique thing, the skipping rope is too long. It has to be 6 inches above your head. And I've had people just change the length of their skipping rope and no longer leak. It's to do with speed and how much it comes around and how much you use your upper body to bring a longer rope around. So this is an easy change. Now, preface on that, measuring the rope by pulling it up to your armpits will not give you the 6 inches. I'll tell you that, because your torso length, your leg length, and your arm length will all affect that 6 inches. So don't use that as your measurement. Actually take a video, put it in slow-mo, see if you can see if you're 6 inches above your head. That's for those double unders or skipping CrossFit type stuff.
I'll jump in on that too, no pun intended. And just saying too, if jumping isn't what you're looking to get back to, maybe it's another type of impact exercise like running, or something with more like, you know,
change in direction
and stuff.
Jumping jacks, whichever.
Yeah, like we'll often design more a custom program. The pelvic floor muscles are like every other muscle in our body. It's a use it or lose it kind of situation. And if you haven't used it for a while in the same capacity, because of pregnancy or injury or whatever else, then like all the other muscles in your body, it needs that time to build up strength. And so I see a lot of runners in my clinic, and we give them that space to build it up, where we're doing a lot of interval training of, you know, walking for a minute, running for a minute, and then we just slowly increase the load on the tissue. And we know generally in the physio world that gradually increasing load on tissue is going to decrease the risk of injury. And so we treat the pelvic floor very similarly.
Great answers. I love that you have brought us into conversations about sport physio as well, because it is about remaining active. I have just a couple more questions in the time we have left. This question is, will weight loss improve symptoms of incontinence?
That's a great question. We do know in the research that an increased BMI or body mass index is associated with an increase in stress urinary incontinence. I would say that it can be part of the puzzle for some people. It's not something that we're going to recommend to everyone. In no way am I going to tell you know, my mom that's coming in 6 weeks after she delivered, who's suffering from incontinence, that, you know, you need to lose weight. Me and Keeley had been talking about this, and I think we're kind of on the same page where, you know, It is not required.
It's not required. I think most people, sometimes when I see them, because the research says that sometimes when they go to the doctor's office or whatever, they're told like, oh, just lose 10 pounds, it's going to help. Well, anyone who's gained weight or has weight issues knows that that's near to impossible, like a task to accomplish. So I preface, like, you don't need to get better by losing weight. You can make yourself stronger. You can change how your muscles work at any weight. Okay. You do not need to lose weight. You can do other things besides that. Will it help sometimes? Yeah.
For sure. And if that is the approach, again, we strongly recommend that people use that interdisciplinary team. Make sure you're consulting your pharmacist to see if the medications you are going to even make that so that you're successful. Include a dietitian or a nutritionist, consult your doctor. So we want all team members on board so that there's success if that is going to be your goal.
So I have 3 questions and 3 minutes. So hopefully they'll be easy to answer. Okay. This one's fun, and I'm glad we're including it. One of our audience members asked whether or not pelvic floor health is applicable to men as well.
Most definitely, yes.
Men don't talk about it at all.
Yeah.
It's hard for them to even find us or access us or get information because they don't talk about it. So if any are listening or your partners are listening, you can tell your partners they can get help as well. Yeah.
I would say it is actually in some ways almost harder for men to access it because I know there's a lot of pelvic physios that don't treat it. They might not feel comfortable. So sometimes you have to do a little bit more digging into finding the right person. Specifically if you're looking for private
So some don't treat men. That is true. Yes. Yeah. So you do have to ask if they treat men. Some women are just not comfortable with that. Yeah. And there's only 1 or 2 male pelvic health therapists in Alberta. One is in Calgary. And that's all I know.
Yeah.
All right. Well, that was a little bit of drift from our normal agenda, but I said it was a fun question and I thought it was worth bringing into the conversation. 2 final questions. What last piece of advice would you give to our audience today that would help them navigate the health system more effectively in dealing with the conditions that we've been talking about this morning?
I would say my first piece of advice is just have a conversation about it. There's so much shame that I think is around this. People feel very embarrassed to talk about it with their healthcare providers. And I think in just bringing it forward, it'll help normalize. So that would be, my first piece of advice.
Yeah, and then some approach their providers, but don't get the direction they need. So keep looking. Even from this lecture, if you've heard, and it's honestly a lot of word of mouth that people hear about us at this point. So if you had success with a pelvic floor physio, tell your other healthcare practitioners, whether it be an acupuncturist, a massage therapist, a pharmacist. The more people hear about us as a resource for this problem, the more likely they're going to direct you for help. But if they don't know, well, then how are they going to tell you where to go? They don't know. So
and I'll thank you, Carmen, because this is just one platform where we as physios can educate the people out there of what we do, which is fantastic. I think as physios, we need to promote ourselves more.
Yeah.
Thank you. That was very insightful information and informative for the people on the line that want to have a better conversation with their doctor. One final offering to both of you. What is the most important thing that the WHC can work on to improve women's access to the right treatment and support at the right time in this area?
Well, I think even that ties into the last question. We put on the website, ladies, that assessment form. Go and print it off, fill it out, present it to your healthcare provider. WHC is putting that up there for you so that you can have access. Usually when people see me, I have to email them that form. It's available now to anyone to use for any practitioner. Go see what those questions are. WHC is supporting that for you so that you can go and get that information and start to ask those questions.
I also would love just the support of the WHC in lobbying the government. I think as clinicians, that's just something we don't do. It's not part of our strength. And I think that this type of care should be offered to women across the board, no matter what income level you're coming from. And so I think that funding for it is hugely important and a huge barrier for people coming in and getting treatment.
Thank you very much. We actually ran out of time before we ran out of questions. And so that's a really good sign that we had a highly engaged audience. We will go through those questions. This is a message to the audience. We will go through all those questions and find a way to answer them for you, either through, we can attach them to a blog. To this presentation will be on our website and is available to members after the session. And we'll do what we can in some way to answer all of the other questions that you asked. So thank you very much for being such an engaged audience. This is also my opportunity to thank Chantal and Keeley for being exceptional, interactive presenters, having a really bold conversation about incontinence. I am going to do my best to not be embarrassed about this conversation in the future, whether it's with my doctor or my daughter or my friends. And certainly we'll be telling people that if this is what's going on in their life, they should be talking to their physiotherapist. And so thank you very much for that. I would also like to say thank you to the behind the scenes volunteers, the technical crew, Catherine, Tammy, Natasha, who have all donated their time to make this webinar possible. Our speakers are also volunteers. And there's a planning committee that put this together. And none of this would happen if people weren't incredibly passionate about making a difference in women's sexual, menstrual, and reproductive health. And we, the Women's Health Coalition, is blessed by amazing volunteers. Our next webinar will be held on Saturday, May 8th at 10 a.m. The topic will be menstrual and reproductive health with Dr. Soni Singh. He's one of Canada's leading gynecologists in uterine fibroids, endometriosis, and minimally invasive surgery. The session will be very, very applicable to healthcare professionals, and it will also have some practical tips for patients in helping them navigate the system. And this is a bit of a only for those online. We will also, as a part of that webinar, be announcing Women's Health Week, the inaugural Women's Health Week from May 8th to 15th. And there will be a lot of exciting news, activities, and engagement with stakeholders and government that will take place as a part of that week. So I hope you mark your calendar, and I hope you check in on the Women's Health Coalition website frequently to hear news of that exciting week. So again, thank you for joining us. And if you're not already a member, I hope that this session has encouraged you to become a member so that you can continue to access these webinars in the future at no cost. So thank you very much and enjoy the rest of your Saturday.